Good afternoon, everyone. This is Professor Dunham, and this is going to be one of several little mini reviews that I'm going to post. Um, on your next exam, you will have these chapters that we have studied for the last couple of weeks. And so I want to make sure that you really understand the first stage of labor, okay? Because you have 4 stages in the stages of labor. And the first stage is the longest stage. So on that, we're going to go ahead and review it. So in the first stage of labor, you have the different phases. You have the latent phase from the beginning of when true labor starts until she becomes 3 centimeters. Now, just some books have 3 to 4, and that's fine. But just remember the latent phase is from the beginning of true labor to when she gets to be 3 centimeters. What happens is that the mom starts to get, she's anxious. She wants to talk. She's able to continue usual activities, walk around, doing things what she has to do. And the contractions are usually mild and about 10 to 20 minutes apart, and they last from 15 to 20 seconds in duration. Now, as she gets a little more active, then the contractions become 5 to 7 minutes apart and 30 to 40 seconds in duration. Now, when I say duration of the contraction, I'm meaning how long it lasts. How long it lasts. So also another way they put it is duration is the time between the beginning and the end of a single contraction. Okay, now the active phase is when she goes from 4 to 7 centimeters. Now, during this time, of course, mom is going to get a little bit more anxiety, increased anxiety. She's increasing discomfort and unwillingness to be left alone. Her contractions are moderate to severe, and now they're like 2 to 3 minutes apart, and they're 30 to 60 seconds in duration. Now, during the active phase, it's very advantageous. If she wants to have a epidural, then she can. Now is a good time to get an epidural. And remember, when you get an epidural, you're going to make sure her blood pressure, you take her vital signs, and then you report that to the anesthesiologist. And the anesthesiologist will go ahead and give an order to basically bolus her with 500 to 1,000 mLs of, say, lactating ringers. You give the bolus in order to prevent her blood pressure going down. So you're preventing hypotension. I don't want the blood pressure to bottom out after I give her an epidural, which sometimes can happen as a form of anesthesia. Because when mom's blood pressure goes down, the baby's heart rate will go down. Okay, now the next phase of the first stage of labor is called a transition. Transition is from 8 to 10 centimeters. And now her behavior, say if she doesn't have an epidural, you'll see some behavior changes. It's a very anxious time because, she could have some nausea. And then she has extreme irritability, sure. And then sometimes they don't even want to be touched during this time. And sometimes the poor dads or the partner or the support person in the room gets kind of beat up during this time. It's only because it's extreme pain and the feeling of the baby's head pressing down is a lot of pelvic pressure. So you'll see that now the contractions pattern for that would be like 1.5 minutes apart. They're pretty close together, and they're lasting from 60 to 90 seconds in duration. These are firm contractions. These are painful contractions if she's not anesthetized. And then you'll go into the second stage of labor, which is what? Pushing. Pushing lasts from 0 to 2 hours. If the baby is in an OA position, that's occipital anterior, That means that the back of the baby's head is facing to mom's anterior. That means that she'll do pretty good pushing. Pushing is hard, and you have to, be very positive and help them. And as your role in there, you have to maybe you may be helping hold her legs, while the RN's on this side. Maybe you'll be on this side holding the legs up so that she gets a good pushing, okay, a good force down, and she only pushes with a contraction. Now, from that stage, you're going to, when she is ready to deliver, okay, well, that will be in that stage. She'll deliver the baby. Okay, so now we got delivery of the infant. Okay, and now the next stage is the third stage, and that is when the placenta is delivered. Now that can take anywhere from 0 to 30 minutes. We do not want to rush this stage because during this stage, the placenta has to break away from the endometrium, and it needs to pull away nicely. If you pull on the cord to get the placenta out, what happens is that you can have retained placenta. And so then you have a patient that is set up to hemorrhage. And we don't want to do that. So we wait. Everybody's wait patiently for that placenta to deliver itself. It has its own stage. And then after she delivers the placenta, the RN will give the Pitocin through the IV. And so that makes the uterus contract after the placenta's out, because when the placenta comes out, you have an area that's like a cut. And so that area is an open area, and it has to what? It has to have pressure to decrease the bleeding. When you have a cut on your arm, like here, when you have a cut on your arm and it's open, it'll bleed, correct? Yes. But if I hold pressure on this cut, it will what? Stop bleeding. Well, it's the same thing. So now we have her contracting. So these are what we call the afterbirth pains. And so we have stage 3 completed. So now we're going to go into stage 4. And stage 4 is your recovery time. And that goes from in the immediate recovery, that can last up from to 2 hours after delivery. And then she'll be in the long recovery called postpartum. And what happens is that can last for 6 weeks. Now she'll be going home in a couple of days. So when you do discharge planning, you have to really outline everything in her discharge planning. So say we have a question about discharge planning. So what would you want to include in your discharge planning? Okay, well, she's got to be let know if she gets a fever. All right, fevers are never good. It's like a 100.4 greater. That's a fever. Okay, and so she has to be told this is the time. If you get a fever, you need to call the doctor. If she has a foul smelling lochia, remember lochia is the discharge, and right after delivery, the lochia is lochia rubra, and so her lochia should not have a foul smell to it. If she has any type of visual disturbances, I would want her to call us, okay? Because what am I thinking when I say visual disturbance? I'm thinking preeclampsia. Yes, you can get preeclampsia even when she goes home. And then if she has pain in her calves, that's not good because due to the high coagulation situation in her blood, she's prone to a DVT, deep vein thrombosis, and that usually starts in the calf, and that can very fast dislodge itself and travel up and end up in the pulmonary artery, and she could have a pulmonary emboli. Okay, so that's pretty significant, and I would want her to report that. So if you have any, any of those disturbances, in another one too, I just was thinking, she goes home, she has lochia rubra. Lochia rubra is about 2 days of heavy bleeding, at the delivery, and then it starts to get lighter. So by day 3 or 4, it turns into what? Serosa. Okay, and that's like blood with mucus. So it's like looks more pinkish than the bright red bleeding that she'd had for the first couple days, 2 days. And now it's lighter. It still has blood in it, but it's mixed with mucus. And so that would last up to about day 13, 14, a couple weeks. And then it goes into lochia alba. Now, alba is white. It has more WBCs in it, and it has mucus. It's more mucusy. So if she was home and her lochia went from serosa back to rubra, that's significant. And with a temperature and then that rubra changing, that's not good. Okay, we don't want that. That should be reported immediately. Because what am I thinking of? Placenta that had been retained placenta up in the uterus. So I don't want her sitting home and having that kind of bleeding, because she can hemorrhage. Okay, so that's pretty significant. And when you have your discharge planning, you need to think about what are you going to give her, so when she goes home, she'll be okay. Okay, so and then if she's going to breastfeed, you got to think about what you're going to tell her about breastfeeding. Okay, so those are the stages of labor. So please, review these over and over again, so that you got them at the tip of your tongue. Your exam will have probably a question on that. And I'm going to tell you, HESI usually uses this. What they do is they give you a scenario, and NCLEX too will do this way. They give you a scenario, and you have to know what's going on with the patient so that you can answer the question properly. Alrighty, so now we'll go right into true labor versus false labor. Now, true labor is uterine contractions that are what? They're pain in the lower back that radiates to the abdomen. Now, the significance of them, they're regular rhythmic contractions. Okay. And what happens, they increase when you have sent the patient out walking. They increased. And then you have for cervical dilation and effacement of the cervix. Now that's true labor. Okay. Now, you false labor, you would have discomfort that's more localized in the abdomen, no lower back pain, and contractions actually decrease in the intensity when walking. And they actually decrease not only in intensity, but frequency when walking. And then you have no cervical changes. There's no effacement and there's no dilation. So your patient's not in true labor. Now, yes, they'll probably think they are, and they'll kind of probably get very discouraged that you're saying that to them. But how I always handle it in triage is your body is gearing up. Okay, so it's impending labor. So go home, rest for a little bit, and maybe take a shower. So using some non-pharmacological means of pain relief, and walk around and see if you can get the contractions. Now, when I discharge them home, I'm always making sure that her vital signs are stable, and the fetal heart rate is stable, and the normal fetal heart rate is between 110 to 160. So I send her home, and I tell her, if when the contractions become regular, when they intensify in the intensity, then come back. Also, I make it a point to let them know that they have ruptured membranes. They need to come back to the hospital, because once the membranes are ruptured, we need to get her delivered at 24 in 24 hours, because once you go past 24 hours, you start getting into possibility of an infection. So we like to get them delivered. Okay, so we also talked about in the intrapartum, which is the labor. We also talked about station of the baby's head. Now you might have a scenario where it's going to go through and they want to know, you have to know what the different station is to order to answer the question. So if you have a baby that the head is at a zero station, zero, you're right at the level of the ischial spines. And then anything that's above the ischial spines would be a minus, like -1, -2, -3, -4. Anything below the ischial spines is a plus, like +1, +2, +3, +4. Okay, and so that's where when we go in, we can feel the ischial spine, and there's really pointy little things, and they stick out, so that gives us a good landmark. Okay, so that's station. So you might have a question that the scenario tells you that she's 2 centimeters, she's 90% effaced, and the head is at a -1 station. So you would have to know that she's 2 centimeters, so she's 2. She's in what phase of the first stage of labor? She's in the latent phase. Okay. 90% effaced is great because that means the cervix is really getting thin. Okay. And the head is at a -1. So it's just above the ischial spine. So she's probably getting ready to have good labor. Okay. So that's how you look at this. Alrighty. We talked about having support person with the patient in order to give support, and the reason why is because everybody handles pain different, and it's always nice to have somebody in the room. But if they don't have anybody, they can have a doula, and doulas are they're trained. They're not medical. They don't have to be medical, and they're trained to support the patient in psychological, emotional support, and getting them up, walking with them. And so they really are very good. They work really well with the labor and delivery nurse. Okay. We always want to assess their pain level because, as I said, pain is very subjective. And so it's up to the patient. She says she's in pain, she's in pain. But the stages, the phases of the first stage of labor. So a little bit how they should be reacting. And so then you can make your nursing assessment. Now, okay, now we're going to talk a little bit about presenting parts. Okay, so you have the vertex, which is your head down. If you have a breech, say the buttocks is presenting, okay, down in the pelvis. And then if you have a transverse, the baby's laying horizontal. Okay, now if you have a breech or you have a transverse presentation, they need a C-section. Okay. It could be on your exam or HESI. Again, you would have to know what breech is, and then you would have to know what transverse is in order to answer the question correctly. So again, breech, the buttocks is presenting, all right, and a transverse is your shoulder that is presenting. Okay, those two they get sectioned. We like the baby to be in a vertex presentation. That means the head is what? Down. Okay. Alrighty. We talked about the normal fetal heart rate in labor, 110 to 160. And mom's blood pressure should be less than 140/90, less than. And then mom's pulse should be less than 100. And then her temperature course should be what? Less than 100.4. Okay. All right. Now, we always put the patient on the electronic fetal monitoring when she's in labor. That's a standard of care. Alrighty, as we move right on, When I talked about ruptured membranes, we want the amniotic fluid is clear and odorless. Okay. If you notice that there's green fluid, yellowish green fluid, or gold yellow, it can basically be that the baby has had his first bowel movement, which is meconium. He's had it in utero. Now, you can labor her with that. You hopefully she doesn't have a long labor, and you monitor fetal heart rate. The one thing about having meconium stained fluid is called when it comes to delivery, when the head pops out, you must suction the baby with wall suctioning. So it's not the bulb suctioning; it has to be more powerful suctioning, and you use with a Yankar, and you connect that to the tubing. The tubing connects to the wall, and the head pops out, and the practitioner will go ahead and suction the baby out. He'll get as much as he can out, and then have the next contraction, the baby is delivered. Once the baby comes out, we still do not stimulate this baby to cry. We take it over to the warmer, and you would have respiratory therapy there with the nursery nurse, and they'll go ahead and intubate the baby, and then do deep suctioning there to get as much as the meconium out. And the reason for this is you do not want the baby to breathe in the meconium. When they breathe in the meconium, that's called meconium aspiration syndrome. All right. Now, when I talked about the baby in the pelvis and for labor, of course, on one vertex, I said, but I also love to see the baby in an OA position. That's occipital anterior. That means that the back of the baby's head is facing mom's front. I think I said that already, but I'm just going to go ahead and reiterate it now. And then that makes for a nice labor. That's when the baby's head is tucked really nicely down. Now, the other position that can happen with vertex is called OP. That's occipital posterior. The back of the baby's head is to mom's back. Now, that little chin is then up. It's facing up instead of facing down. He can make down the passageway being OP. But it takes a longer labor, and mom has to push a lot harder. Okay, so that's what's important. And during you have a patient in labor, think how you would take care of the patient. So write down, draw a little picture of mom, and draw, do some concept mapping of a woman in labor and the different stages of labor and what happens. So you can make your straight lines off the center, and then you'll be able to see it better as to what happens and what would you do as a nurse taking care of this patient. And you would give a lot of emotional support. We monitor the contractions for frequency, duration, and intensity. We monitor fetal heart rate for normalcy, 110 to 160. And then her progression of labor as to her dilation and effacement. And we only do vag exams when we need to do. We don't do them just routinely every hour on the hour. No. When we see maybe a fetal heart rate go down, we call that a deceleration, then we'll get in there and see what's happening. Okay. And when you have ruptured membranes, if she's laboring and then all of a sudden she feels something wet, she has ruptured membranes, we can test that out with some nitrazine paper. Okay. A nitrazine paper is just simple litmus paper that can be used to, we just rush it through the down the vagina a little bit, and we can see the fluid. Or you can get a little Q-tip and get that out too. Okay, so that's how you test for ruptured membranes. Okay, so you can go ahead and labor her and make sure that you teach her how to do slow chest breathing. Okay, and make sure that she doesn't hyperventilate. Hyperventilation, it has a weird feeling. It gets really like tingling around the mouth, and they can get dizziness, and they get some tingling in their fingers. So what's you as a nurse, what are you going to do to take care of that? So write down the piece of paper. When I ask you what the nurse would do, write down the piece of paper what you would do. Well, I would get her hands over her nose and mouth and have her breathe normally, just in and out. That works. Okay. If she has a little paper bag in her preparation bag, that's great too, because then you just put the paper bag over their mouth and their nose and let them breathe into the paper. That takes care of it. But how about we try to prevent hyperventilation by teaching your patient how to slow chest breathe. So during the contraction, there's 3 phases of contraction. You have the increment, you have the acme or the peak of the contraction, and you have the decrement. As the increment, that means going up, do some slow chest breathing. Slow chest. That means like this. And out. Breathe in and breathe out. Breathe in and breathe out. As she gets higher up on the contraction, then you're going to want her to do a little faster breathing, because that's where the intensity is, the peak intensity. That's why it's called peak, because that's where it really intensifies. So she may have to do a breathing like this. Now, this is a kind of strange breathing. So you would have to demonstrate to her. And when she's breathing, and actually I used to breathe with my patients an awful lot, and I would just and they would follow me. Okay, they would like focus on my face. And then as we go down the contractions, that's called decrement, you go back to slow chest breathing. In and out. In and out. Okay, nice slow chest breathing. And then as soon as she gets down to her resting tone, that's the time in between contractions. Let her just, when she gets down all the way down, just give a good deep breath. Take it in and blow it out, and let her rest. And then the contraction will start all over again. And that's why they call it labor, because it is labor. It's like I actually equate labor to a marathon. And so, that's why we like people who run marathons. They get prepared. And that's why we encourage women to go to childbirth preparation classes to get prepared for labor. Okay, so she gets through all the way to 10 centimeters. She's going to push, and she delivers. She goes now into what? The second stage. Okay, so second stage of labor, that can last anywhere from 1 hour to 2. We usually don't go past 2. Sometimes if you have a multi-para, what they're going to do? They can go real fast, okay? And so they can push those babies out pretty good, because don't forget now, the perineum has been stretched out if this is her second and third baby, okay? First time mummies have a little harder because, excuse me, that's because the perineum has been stretched out with the prior baby. So that's why the old saying is, you never trust a multigravida. Okay, so that's your second stage of labor, and you have to really give a lot of encouragement during the second stage of labor. Okay, and there are always risks for injury. So be careful with their legs, because don't forget, having the legs up for a long time, you can cause that to get a little crampish, okay? And I don't want to cause any problems with the calves with maybe a blood clot. Okay, so that's your second stage of labor. Again, you are monitoring the fetal heart rate with every contraction. And when I see a decel, now let's go over, since we're talking about decelerations, what kind of deceleration would you think you would see during the pushing stage? Well, it would be an early deceleration, because early decelerations are caused by head compression. okay, caused by head compression. Please review veal chop. Okay, and I'll go over with you right now. So if you have your pencil and paper, and write it down. Write down the word veal, VEAL, and write down CHOP. Okay. Next to the V, you put variables, and variables are caused by cord compression. So that's your top line. V, variables. Over here, C, cord compression. Okay, then E would be your early decelerations. E is caused by H for head, head compressions. Okay, and then A is for accelerations, and accelerations are A-OK. All right, and then the last one is L, and L is for a late deceleration. And late deceleration is caused by the uterine placenta insufficiency. That just means that the uterus and the placenta, they're no longer getting along. Nah, they've had enough. They've had 9 months, and so they're not getting along anymore. So that they're not, the blood flow is diminished. Babies will suffer because of that. Okay, because he needs that. He needs those oxygen, and so babies cannot have late decelerations for a long time, because then they get they'll lose their variability. All right. Now we're going to go into the third stage of labor. Now your third stage of labor is what? Delivery of the placenta. So remember, you do never rush the delivery of the placenta. Let it come on its own. And because you can get a complication if you rush it, it's called retained placenta fragments, and your patient will hemorrhage. Okay, so we want to make sure that, it just takes the time. A little clue is when you see the cord hanging at a mom, and all of a sudden now you see more of the cord. That just means that the placenta is starting to come off the endometrium. Always after the placenta is delivered, that's when the RN will give her Pitocin in the IV, and that will make the uterus what? Contract. Okay, Pitocin is a prostaglandin, is a synthetic form of oxytocin, which makes the uterus contract. Okay. And we want that to contract, and I said this in the beginning, is because we want that uterus to clamp down to what? Decrease the bleeding. All righty. So that you have the placenta now delivered. Okay. So now she's going into the fourth stage of labor, which is your recovery. Now, usually the fourth stage of labor lasts from maybe 1 to 2 hours. Sometimes some books say 4 hours after delivery of the placenta, but usually it's about 1 hour in the labor room, and then she gets all cleaned up, and then we get transferred to the mother baby unit. Okay, now there are some complications that can occur during this time, and so you want to monitor mom's vital signs. She's got the pulse ox, she's got the blood pressure cuff on, she has the pulse oximeter on. You're checking her breathing, respirations, and you're checking her fundus. The fundus is the top portion of the uterus, and it must be firm. Okay. I'm also going to check her bladder. I'm looking for bladder distension, because bladder distension can increase when that gets full. That can push the uterus up above the umbilicus and over to the side. Okay. And so then she would have more bleeding. All right. So what are you going to do? You're going to empty the bladder. Once you empty the bladder, the uterus will come back to midline and be at the level of the umbilicus after delivery. Okay. So you got that. You have to be very careful with that. You always have to be on alert for a postpartum hemorrhage. That's why I'm going to check her fundus, make sure it's firm. That's why I'm going to check her bladder, make sure it's empty. If she's getting medication such as magnesium sulfate, you'll be monitoring that. All right. A lot of times on HESI, they'll give you a scenario. And the scenario, you have to know if that's normal or what. And you never want a hemorrhage. And so they'll say, what is the first priority? So read those questions very carefully. All righty. So you're going to keep her in recovery. In that time, the baby goes through his bonding time with mom, and the first hour is called phase 1. Now, phase 1 is when the baby is bonding with mommy and daddy, or significant other, or grandparents, whoever's in the room. Okay, it's a nice time. Baby's awake. Okay. And mom can breastfeed, which is great because then she's even increasing her own oxytocin, okay, from the anterior pituitary. And basically, that's really great because that gets the uterus to contract even more. So that's very advantageous. Okay. And we always want to make sure that when your baby latches onto mom's breast, that it's latched on correctly. The whole entire areola of her breast is in his mouth. If the baby just takes the nipple and that's all he does, it will make mom's nipples very, very, very sore. And what happens, sore nipples become cracked nipples, and they come into mastitis, which is an infection in the breast. So that's why we start right from the beginning, making sure that baby latches on correctly. And I can guarantee that you'll probably see that it's always good on exams and always good on HESI. All right. And during this time that you're the nurse in the during the recovery, you're going to be checking all the things I talked about, and baby, making sure baby is doing well and his color is pinking up. A lot of times babies are born with blueness in their hands and the little feet, and that's called acrocyanosis. Now that's normal, okay? Right after birth, that's normal. But within a few minutes, they get pink all the way through. They're really good. So what's the score that you're going to be doing when this baby's born is called the APGAR score. And that was devised by Dr. Virginia Apgar. And why we do the APGAR score is basically to know what level of resuscitation this infant needs. So you want to be very careful when you're studying the APGAR score that you know what scores are good. So like a score from 7 to 10 is good. And then a score from 4 to 6 needs moderate resuscitation efforts. You might need some drying off, which is okay because babies come out there wet. You need to dry me off, nurse. Because why? Because I'm worried about the baby's temperature, and that's called thermoregulation. So I want to dry him off real quick. And then your APGAR score 0 to 3 is severe need for resuscitation. 0 to 3 is the baby is in trouble. Because if you think about it, you have 5 areas for evaluation, 5 criterions. So what you have the heart rate, you have respiratory effort, you have muscle tone, and you have reflex or irritability, and you have color. And you give them all a score at 0, 1, or 2, based on what you're seeing. And so if you have a heart rate that's absent, obviously it's going to be a big fat 0. Okay, under 100, you're going to give it a 1. And then if it's 100 or greater, you give it a 2. Okay. And then his respiratory efforts. No cry is 0. A weak cry is 1. And a biggest cry is 2. And that makes sense, doesn't it? And then muscle tone. Baby comes out, he's flaccid. That means he's limp, like a they call that a limp dish rag. And so then it's a big fat 0. If he has some type of flexion, okay, he's trying, he gets a 1, and if he's totally flexed, he gets a 2. Okay. And then you have reflex irritability. If you take it and you take your finger and on his little foot, we used to just tap. See my hand doing just tapping? Now, if he has no response to a foot tap, he gets a big fat 0. If he has a slight response to my foot tapping, like a grimace, and a lot of times HESI uses that term, grimace, then he gets a 1. He's trying. But if he quickly removes his foot, he doesn't like it like that, right? Then he gets a 2. because that's good reflexes. And then color. If he's pale and he's kind of dusty looking, cyanotic looking, it's a 0. That would make me kind of very, very worried. And then if he's acrocyanotic, again, that means my little hands and feet are blue, but the rest of me, my body is pink. Okay, so that's a 1. And then if he's totally pink, he gets a 2. Okay. We do it in the labor room. We do it at 1 minute of birth and 5. And yes, baby comes out, has a good cry already. We can do APGAR scoring while he's on mommy's chest. Okay. A lot of times I've had my babies come out and they're crying nicely. I put them right on mom's chest, and we can dry them off, and we can already, I'm checking his heart rate and his color, and I can tap his little foot and see what he does. So I can do all that on mom. Again, I'm trying to promote the bonding. Okay. And then in the labor room, the nurse will obtain, footprints, and we'll tag the baby. Remember ID bands? ID bands have to be on before the baby leaves the room, no matter where you're delivering. If you're delivering in the labor room, the baby don't come out of that room without being tagged. And if you're delivering in the operating room, same thing, has to be tagged. Baby gets 2 tags, mom gets a band, and the significant other that she says, I want that person to have a band, then you put the band on. Okay. So that is a little of an explanation of intrapartum that I wanted to go over. And I like to go over a few. Oh, also, you can do the eye ointment on the baby. It could be erythromycin, and we're preventing gonorrhea. And a lot of times Hesse had that. Hesse always has a question on the medication given to newborns. Every newborn gets it, and it's given in a ribbon fashion. So that means you put a little bit, and then you come back half, and then you go again, and then you come back half and go again. That's called a ribbon fashion. Okay. And again, we place a thin line of ointment along the entire lower lid in the conjunctival sac. Okay. And use only 1 tube per baby, and you throw it away. All right. And then you can manipulate the upper lid to ensure a complete eye coverage. And then after a minute, if there's any little excess here on the side of the eye, you can wipe that away with a sterile 4x4. All right. So if I was to ask you, a patient is laboring and she's dilated to 8 centimeters. Now remember, 8 centimeters, we're in transition. Okay. And she desires to push. Yeah, they have so much pelvic pressure. What instruction will the nurse give to prevent pushing before being fully dilated? Okay, I'll give you a few minutes to think about it. Okay. Remember when I said make her puff her cheeks out? And I said, remember, put your finger up and you look at the finger and pretend it's a birthday candle. And so I would tell them to blow out the birthday candle. And I hope you try this at home. If you're blowing out, like you're having a birthday candle, you can't push. And it works like a charm. And it gets them through, and maybe that's 60 seconds that they have this strong urge to push. Because you don't want to push till you're 10 centimeters. Okay. Another question, if I said the client comes in with spontaneous rupture membranes, what finding would the nurse recognize as an indication of infection? Okay, so you have spontaneous rupture membranes. Okay, and it should be nice and clear, correct? Because that's what amniotic fluid is, and it's odorless. Okay, so she comes in and she's got some discoloration to the amniotic fluid, that means that baby had a bowel movement. And so that wouldn't be good. That would be, oh, not good. And also, if she has a foul smelling amniotic fluid, that means there's an infection going on. Infection. Okay. If you had a baby that was born and now you have to do the APGAR score and your score comes up with a 6, what would be the nurse's next priority? Okay, so remember, we talked about APGAR score, and I went over the different scoring criteria. And so if you had a 6, that falls into the category from 4 to 6, needs moderate resuscitation efforts, moderate. So that means you would provide some gentle stimulation. Okay. Remember, 7 to 10, we're good. Just dry me off, nurse, okay? Because I'm kind of wet in the air. When you come out of a pool, right? I mean, you want to be dried off, or come out of a shower, you want to be dried off because you're wet, and the coolness of the air makes you feel cold. So dry me off. Okay. And then 4 to 6, you need moderate resuscitation. So provide some gentle stimulation. And then 0 to 3, you need is pretty severe, and you need some good resuscitation efforts. Okay. All right. If you have a client that gets a narcotic during the transition, okay, we don't like to give narcotics during transition because it goes right to baby, and then baby would get sleepy. So you want to avoid. And so what do I want to avoid? I want to avoid respiratory depression. Alrighty. We also talked about epidurals, and we talked about bolusing with what, at least 1,000, sometimes 500, all according to anesthesia, or 1,000. And I want to give her the IV fluid bolus in order to what? What am I preventing? Give you a minute to think. Think about it. I'm preventing hypotension of mommy. Okay. We talked about bonding and attachment. So what is the best way to promote bonding following a delivery? I'll give you a second. Remember, I just said it's skin to skin, folks. Skin to skin is the best way to start the bonding process. As long as baby's doing okay, has a good APGAR score, comes out just screaming his head off, which I just love, we can do the skin to skin contact. Okay. If your patient has spontaneous retro-membranes, what nursing action is appropriate? What are you going to do if your patient comes in with retro-membranes? Well, 1, I'm going to look at the color. Yeah. 2, I want the time. What about, before I do any of that, what am I doing? I'm putting the fetal monitor on. I want to assess fetal heart tones, because what am I worried about? I'm worried about a prolapsed cord. So I'm going to put the fetal monitor on. I want to know how much. I want to record the amount. And I said the time because of the risk of infection after 24 hours. All righty. We talked about doulas. They're really good in the labor room for preventing, giving emotional support to the patient. All right. Now, I noticed on the quiz, a lot of you missed out on a question about breast engorgement. So you got a postpartum patient who has pain, and she wants pain relief from breast engorgement. Now, you can get breast engorgement even if you're breastfeeding. Doesn't necessarily just for the non-breastfeeding. So what can you give in between each breastfeeding sessions? And it's a non-pharmacological means. It's not medication. you put cold packs on. Then nice cold packs, and it releases the tightness. And what it does, just it helps to prevent breast engorgement, because when the breast gets so tense and distended, they have a hard time getting the milk. So early, regular, and frequent nursing also helps to prevent breast engorgement. Okay. All right. Put that baby to breast. And baby should go to breast in the very beginning every 2 to 3 hours. And the first substance that's produced by the breast is called what? There's different phases of milk. It's called colostrum. Okay, so colostrum, transitional milk, and mature milk. So, late in pregnancy and for the first 2 days after birth, colostrum is secreted by the breast. And then it's like a yellowish fluid, and it's rich in protective antibodies. It provides protein, vitamin A, vitamin E, and essential minerals. But it is lower in calories than milk. But it's good. And this colostrum has like a laxative effect on the baby, which aids in getting rid of the meconium. It's good stuff. And that's what I always tell my patient. It's good because it has a big purpose. Because a lot of moms go, it's so watery, it's so thin. How do I know my baby's getting what it needs? They do. And how do I know that breastfeeding is successful? It's because my baby has 6 to 8 wet diapers per day. Okay. Now, how often should the breast be pumped? Well, if she's pumping her breast, say she delivered a preterm baby, okay, preterm. So she's going to pump her breast. What information should the nurse give? Well, I would tell her to pump her breast, each breast, 10 minutes every 3 hours. Okay. Because, regular breastfeeding is hard on the preemies because preemies don't have a real good suck. So sometimes preemies have to have garage feedings. That's where they put the tube in. So you can still breastfeed. Mom can pump and then give that milk, that colostrum, to the nurse, and then they'll be able to give to the baby. Okay. Alrighty. Let me see what other questions I can come up with. Remember, you always want to coach your patient during labor. Hemorrhage. Okay, we talked about hemorrhage in our last lecture. And so you want to always assess for hemorrhage. So we talked about mom's pulse being low after delivery, called bradycardia. So when you're taking care of your patient in the recovery or a mother-baby unit, she could start to increase her pulse. All right, you're going, now she was a lot lower before, but now she's like 110, 120. I got some tachycardia going on here. And then you check. What am I going to check for? I'm going to check for the fundus. And I want to see what her flow of blood is. And she has a continuous flow of bright red bleeding. We got a problem. If she's passing large clots, not normal. No. She saturates a peripad, not normal. Like 3 times within an hour. That's a lot of blood. And in your book, that has a really good picture of peripads being saturated. Hemorrhage is PPH, we call it, is a septical coblu, and we treat it as one. And you have to get on top of it very quickly before it gets worse. That's why the signs and symptoms of a hemorrhage. And so if you're not too sure about that, be sure to dive into that book and read more about it. Because I know Hesse has a question about a hemorrhage. And reason why is they want to make sure that you know what to do in a hemorrhage. Okay, and we talked about that already in the beginning of this little mini series. All right, we talked about bladder distension and what you're going to do. You may have, you see that the uterus right after delivery is high and is over to the side. What did I say? Check for the bladder. Okay, it's high and over the side. We know that after delivery, the uterus should be midline at the level of the umbilicus. Okay, and so if it's displaced, that means something is displacing it. So that's the bladder. The bladder is pushing up against the uterus and moves it over to the side. Okay. Alrighty. Be sure that you know, again, the different stages of labor. So we got the first stage with the 3 phases, and that's when she's in labor. Okay. You have the latent phase, the active phase, and the transition phase. Okay. Then you got your second stage is pushing stage, delivery of the baby. Third stage, I can hear you. What is it? It's the delivery of the placenta. And the fourth stage is recovery. Okay. So after she delivered, she had this pretty big baby. They probably had to give her maybe an episiotomy. All right. And so if they give her an episiotomy, she's going to have some discomfort. Okay. Remember RETA, your assessment of episiotomy. Redness, edema, ecchymosis, drainage, and approximation. So what are you going to do for pain relief? Non-pharmacological. I think somebody said ice packs. You apply ice packs to the perineum. That will help with the bruising and the swelling. It certainly does. And you do ice packs for 24 hours. And then after that, you can, if she wants to, she can do her sitz bath. Nice warm sitz bath. And remember, after every time she urinates or she has a bowel movement, we do pericare. Okay, pericare. Take a little bottle of warm water and just go over the perineum. Okay. All right. Be sure that you review too, again, the non-pharmacological means of pain relief for, the different dilations. So if you have a woman who's in early labor, remember she may be dilated from 0 to 3. Okay, that's early labor. So which of the following pain controls is kind of appropriate for somebody who's in early labor? Well, you wouldn't be giving nitrous oxide. No, that's for delivery if they needed. IV Demerol or well, we didn't even use Demerol. Statol, anything? No, that's way too early. Okay. She's more of getting an active phase for that. And a pudendal block, know what a different pudendal block is. And a pudendal block is it's like a local. What they do is they use a long needle and they go right into the pudendal nerve, and they deaden the pudendal nerve, so that when they have to do like a episiotomy, that they can do it. So if you have somebody in early labor, again, non-pharmacological, so you could look at effleurage, you could look at hydrotherapy, skin stimulation, touch. Yeah, touch. I love the effleurages. It's really good for relaxation. So, you have to know, in order to answer a lot of the different questions, you have to know what happens. And that's why today I decided to do a little mini series upon what's happening in each phase of the first stage of labor. Okay. Okay, so what is a precipitous delivery? A precipitous delivery is a delivery in birth. So it's labor and birth that occurs all within what? 3 hours. Okay, 3 hours. So it's quite quick. Now, mom can have lacerations from it because the baby came down so quick. Baby can have some respiratory depression at birth because he came down so quick. So mom can also hemorrhage because of the precipitous delivery, because it's just so abrupt, and it's so high intensity. And so after she delivers, the uterus could be very boggy, and so she could hemorrhage. Because remember, you can hemorrhage from a soft, boggy uterus. And then she could also, I said lacerations, she could get a hematoma, vaginal hematoma, because of precipitous labor and birth. And I'm going to tell you, the worst thing is she can have a uterine rupture because why? Because she's experiencing hyperstimulation of the contractions. Another term that you may see on HESI is called tachysystole, which is another term for hyperstimulation of the uterus. Never good. Okay, never good. All right. If mom, there's a couple ways. If mom is in the second stage of labor, so she's pushing, and she gets real tired, maybe, you know, she needs a little help coming around that pubic bone, they can use forceps, and forceps can cause the baby to have facial paralysis and maybe a little laceration on the scalp. Not good. They can also use the vacuum extractor. And remember the picture on your slides, the vacuum extractor is a circular little cap, looks like a little cap, and we put it on the head, and we have a little pressure gauge, and when mom pushes, we use the vacuum to help mom push that baby out, and that's what it's doing. So if what happens is baby has this little mark on his head because you can see where the vacuum extractor was placed. Okay. Go over a couple drugs. Magnesium sulfate, which we use to we use that in treating what? Preeclampsia for the to prevent a seizure. Okay. We use it in preterm labor to stop contractions. We have to be very careful with magnesium because we can get magnesium sulfate toxic. And so you have to watch it very closely, because the first sign that you have toxicity is that you lose the deep tendon reflexes, and also her breathing will get erratic. Okay, because it works, it slows down the smooth muscles. Okay, well, the entire body. Okay, because magnesium is a central nervous system depressant. All righty. Remember that mnemonic that I wrote to you in one of my announcements about the interventions that we use when a baby's heart rate decels. So it's called LION. So write on a piece of paper, LION. So L stands for left lateral. I stands for IV. Okay, you're gonna give her some fluids. O stands for oxygen, because you're gonna give oxygen, say 8 to 10 liters via face mask. You're going to, and what's the last one? N. N is for, hey, I need help in this room. You know, I can't do it all by myself. Somebody call the doctor, and let's because my baby's in trouble. You know, baby's heart rate goes down to 90, and especially if it's after contraction, because what's that? That's a late deceleration. So I want to go ahead and get her on her side. You never put any patient on their back, because you can cause them to have supine hypotension. So always have them on the side. So remember that LION mnemonic, because it comes in handy. All right. Talked about lochia. So lochia rubra, and for the first couple days, okay, 2 days, it's bright red, and then it goes into lochia serosa, and serosa is like mucus with some pinkish in it. Okay, it still has some blood. That's what the pink is all about, but it's diluted because of the mucus, because it's getting lighter now. Okay, and then you have lochia alba. Okay, all right, and she just has to monitor that, and we talked about that earlier today. All right. Another medication that I want you to be aware of and to look up is called terbutaline. The other name for terbutaline is also brethine. Okay, now terbutaline is a tocolytic, and it's administered sub-Q, and it stops contractions really quick, real quick. But the main thing about this is that you have to monitor mom's heart rate. Okay. Because it increases mom's heart rate. So if you have someone who has hypertension, you can't give this drug because it has, cardiac side effects. And so the biggest cardiac side effect is increased pulse rate and blood pressure can occur. So don't want to do that if I have a patient who is preeclampsia. Do not give breathing. Okay. So that's why if she's getting breathing to stop contractions, you have magnesium sulfate going for that person with what, preeclampsia. Okay, because teredoline it works really, really quick, but it also has a lot of cardiac side effects. Please review, the epidural and the pudendal block. These are two things that you can give to provide perineal pain relief. Okay. All right. We talked about induction of labor. That's where, she has not gone into spontaneous labor on her own. So she might be post-term. So you might have to do an induction. But not everybody can have an induction of labor. If you have a baby that's in an abnormal fetal position, like we talked about before, if she has a transverse line, no, do not do an induction. If you have a breech, you're not going to do an induction. It should, you're not going to have a vaginal delivery, so you're going to be doing C-sections on those kind of patients. So basically, if you have somebody who has gestational hypertension, you can rupture membranes without spontaneous labor, you can do an induction. Okay, so go over the contraindications for a labor induction. Also a VBAC. Somebody is having a vaginal birth that's a cesarean, we do not do an induction of labor. No, we can't. Cause why? Because we cannot give them Pitocin. Good. Okay. All righty. The other day on the quiz, it was I think there was a question about episiotomy, and then maybe that she had maybe a 3rd degree or 4th degree. I think it was the 4th degree episiotomy. And what kind of diets would you want her to take in? Well, remember, it's a high fiber, and lots of water. Keep it all flowing. Keep the peristalsis going in order that she can evacuate. It's pretty tough on these ladies that have 3rd degree and 4th degree episiotomies or lacerations and following a vaginal delivery. Yeah, and they have to eat a high fiber. All righty. When you're studying epidural, study the risk factors that are associated with the epidural. Remember, epidurals, they numb the mom from the waist down. So there is always a risk for injury because she can't feel anything. So, you want to go over those. We talked about non-pharmacological methods. So go over those. Always have Narcan in your room for a patient that you gave a narcotic to and that she's almost going to deliver it. Because these babies, those narcotics go right across the placenta, right to the baby, and a baby can be very sleepy at birth. So you give them a narcotic to what? Reverse that. All right. We talked about true labor and false labor. We talked about what's a good way of stimulating labor, which is what? Walking. I always have my patients walking to stimulate those contractions. As long as fetal heart rate is good, mommy's blood pressure is good, then I can send her out walking. We talked about ID bands already. We had that even in the lecture. We talked about fundal massage. We talked about yesterday. We talked about Kegels exercises, and what do Kegel exercises actually do? They actually strengthen the muscles that are involved in urination, which is good to do all your life, no matter what, so that when you become older, that you don't have some urine leakage. So it's always good to get those muscles good and tight so that you don't have it. All right. If she delivers a macrosomic baby, which is a baby that weighs like 8 pounds and greater. I think it's 8.8, for instance. What complication would the nurse observe in this kind of baby? Well, or would observe, yeah, in mom and baby. So it's going to be a double header. So you got to think, this kind of macrosomic baby, what can it happen? Well, it's a big baby, so baby can have shoulder dystocia. Baby can have hypoglycemia because maybe mom was a diabetic. And so baby's been used to a hyperglycemic environment, and now he's born, is cut off, and so his blood sugar is going to what? Go down real low. And that's the biggest problem with these babies. Mom can have perineal trauma. She can have lacerations, okay? Because those, it's hard to birth big babies. And then the uterus, because it's been not stimulated, excuse me, kind of inflated, I should say, then it'll have a harder time to contract after delivery. So you could have a condition called uterine atony. And remember that? Atony. It's just the uterus is not able to contract like it should. And so now you're going to have a uterus without tone. That's why remember it this way, folks. That's why that term, Atony. A means without, so it's without tone. So you got a uterus without tone. So you have a uterus without tone, you could have a hemorrhage. And these babies, because they're so big, mom's uterus had to be overinflated. And so therefore, when the baby comes out, it's like the uterus is like, oh, kind of like this, okay? So I don't want to contract. And so that's what happens. Okay. All righty. And then we talked about Foley catheters with C-sections, right? And be sure to go over the care of the patient after cesarean birth. What are you going to do as a nurse? And what are you worried about? Okay. So we had that just yesterday in lecture on Tuesday. So just go over that a little bit more. It's right on a slide in your lecture. And then we talked about weaning. We were getting to newborn, and we were getting at the very end about newborn and weaning. When you are breastfeeding, that you create such a bond with your baby. Okay. Babies love that. Babies love being close to mom. Okay. When you're going to wean off the breast, maybe you're a single woman and you're going to go back to work and you just don't want to pump. So you had enough. Or maybe it's time the baby has now teeth. And so it kind of hurts when you kind of sucks on the breast. Okay. No matter what the reason, you have to wean the baby off the breast. You just can't go cold turkey, say. So you want to always abrupt weaning, you don't want to do that. Okay. It's not good. Not good for mom. It's not good for baby. So you want to do it gentle, and you want to do a slow process. And you always wean. You take it from the day, say the day feedings, where he's awake and playing and stuff. And so the last one that I would wean from, it would be the nighttime, because that's the time that's very comforting to the baby. And so that'll be the last one to go. So the daytime one is the one I'm thinking about. We're gonna do first, and then the nighttime would be my last choice. Okay, that's when we're almost done now, and we're gonna take the nighttime away. And a lot of ladies I know, even when the baby does go to a bottle, they do still feed, but feed at night. Okay. You don't ever want to do abrupt weaning. No. Could be easier, but no, it's not good. It's not good for mom or the baby. It's abrupt weaning. Never good. Okay. So that should be a good little review for today. And hopefully that, you've been, doing all your work, and looking at all the PowerPoints that have been given to you and the videos. And so I'm going to say, have a good evening or good day. And I'll talk to you again. If you need me, just go ahead and let me know. Bye bye.